Okay, so Jason, I think we'll get going. So, ladies and gentlemen, it gives me great pleasure to introduce this year's Harland-Smith lecture. And we're very delighted this year to have Dr. Joel Scheinfeld from Memorial Sloan Kettering, who will be speaking to us about retroperitoneal lymph node dissection in just a moment. But before that, I do want to begin with, at first, a land acknowledgement. And I have it on the screen here, and you can read it with me. So we wish to acknowledge this land on which the University of Toronto operates for thousands of years. It has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Our treaty obligations and commitment include learning about the history of these lands and territory and the structured dispossession that Indigenous nations have been subject to by Canada, and learning about justice, equity, structures of power, and to imagine how to build social relations for a different world. We affirm our solidarity with the Indigenous peoples of this land working towards their self-determination and sovereignty. So previous Harland-Smith lectures are here, and I'll just bring to your attention that it was in 1999 that the Division of Anatomy became part of the Department of Surgery, and I think it's a perfect fit. There's nowhere else I would like to see anatomy sit than in the Department of Surgery. And we're very fortunate today to have Cindy Morshead, the division head of anatomy, to be speaking with us and introducing the actual Harland-Smith lecture. But most of these lectures, as you will see in the past, deal very heavily and strongly with the topic of anatomy, which is how and why we choose our given lecturers each year. So with that introduction to the lectureship, I'm going to ask Cindy now to say a word or two about the Harland-Smith lecture, how it came to be, and then we'll turn it over to Neil Fleshner, who will introduce Dr. Scheinfeld more formally. Cindy.
Great. Thank you very much. It is a pleasure to be here today and welcoming you all to the university round, which is called the Harland-Smith Lecture, as Jim has already noted. This lectureship was endowed by Dr. Carlton Smith in honor of his wife, Rita Harland. Both Carlton and Rita were professors in the Department of Anatomy for many years, and they shared a really very deep commitment to the University of Toronto and its students. And then when the Department of Anatomy and Cell Biology was incorporated into the Department of Surgery as the anatomy division, Dr. Smith donated the funds to endow this lectureship, which is really dedicated to surgeons whose career has an emphasis on the integration of anatomical knowledge into surgical practice. So with that, I'd like to thank Dr. Neil Fleshner from the Division of Urology for organizing this year's rounds and invite him to introduce the speaker today.
Thank you, Cindy. Good morning, everybody. It's my pleasure to introduce Dr. Joel Scheinfeld. Dr. Scheinfeld is the Florence and Theodore Baumritter Enid Ansel Chair of Urologic Oncology. He's also the Vice Chair and Deputy Chief of Urology at Memorial Sloan Kettering. He's also Professor of Urology at the Weill Medical College at Cornell. Dr. Scheinfeld is actually from Venezuela, originally born in Caracas, graduated from Cornell University, went on to the University of Florida College of Medicine. He did his urology at the University of Rochester, and then moved on to Memorial Sloan Kettering as a fellow, where he was asked to stay on as an attending surgeon. Dr. Scheinfeld is probably the most well-known retroperitoneal testicular cancer surgeon in the world. He's done over 2,500 of these procedures, and it tends to be a fairly uncommon procedure for all of us. He's an established speaker in this particular topic, and he's authored over 300 papers, including major chapters in DeVita, oncology principles, as well as Campbell's Urology, which is the Bible of urology. He's a member of the GU Surgeon and an AUA scholar. More importantly, I think Joel Scheinfeld is very much a friend to the University of Toronto. He's trained many of us, including myself, as well as others on this call, in retroperitoneal surgery. And I don't know anybody else would be a better lecturer for us today in terms of applying anatomy to surgical practice. So he's going to talk to us about optimizing RPL&D, which are retroperitoneal lymph node dissection, anatomic and technical considerations. Dr. Scheinfeld, Joel, welcome to the University of Toronto, and we'll hand over the baton to you.
Well, Thank you very much, Neil, for the very kind introduction. Can you see the slides? I just want to be sure.
No, you have to share them, Joe.
I thought I put them up. Are they up or not up?
No, you have to click share screen again down the bottom.
All right, we'll try that again. Are we in business now?
Perfect.
Good to go.
Okay. Again, thank you very much for the very kind words, Neil. It's always nice to be back in Toronto in any fashion, see familiar faces and old friends. It's a huge honor to have been invited to give the Harland-Smith lecture. And the topic of RPLND, improving retroperneal lymph node dissection, has been an evolving process for many years, and central to that process has been an improved and a better understanding of the anatomy. And that'll be the focus of this morning's talk. I have no conflicts of interest. And as stated, the goal of the lectureship is to reflect the fundamental relationship between anatomy and surgery. And an in-depth understanding of anatomy is critical to any surgery in terms of surgical planning, optimizing exposure, minimizing adverse events, optimizing clinical outcomes. And the retroperitoneum and retroperitoneal lymph node dissection is no exception. I think it illustrates this concept of just how anatomy and surgery interface, as well as any other site and operation. So RPLND remains a critical component in the management of select patients with low stage and advanced germ cell tumor and other malignancies as well. RPLND is both a staging and a therapeutic procedure, but it must always be done with therapeutic intent. Suboptimal surgery results in suboptimal outcomes. And in germ cell tumors, the consequences of suboptimal surgery, untreated retroperitoneal metastasis include reoperative surgery, relapses, late relapses, and inferior outcomes. So RPLND, again, my interest and focus is testicular cancer, but I have been involved RPLND in selected cases in many other malignancies. The individuals pick the cases, and if we think it's doable, we assist in. And here are a few examples: colon cancer, rectal cancer, ovarian cancer, renal cancer. So the anatomy, the principles of the surgery are widely applicable to many malignancies. Again, we will not address case selection. We will really focus primarily on anatomy and how it interfaces with the procedure and technique. So usually the slide of complications tends to go at the end of these talks, but we're going to put it up front and center and highlight those in red because we'll discuss them as we go along in the talk to see why they occur, where they occur, and how to potentially avoid these. So vascular complications, pancreatic injuries, ascites, cholecystitis, lymphatic problems, and then retrograde ejaculation, which has been a long-term issue with this operation. So I like to think of this operation sort of in three three separate categories here. First and foremost is anatomy. Knowledge of the anatomy is just fundamental. It's absolutely critical to know the anatomy cold, as well as anatomic variants. Surgeons don't like surprises, so you want to really understand where you're headed before you get started. And anatomy helps you achieve adequate exposure, sets up the procedure, and once you're set up, then you go ahead and with meticulous split and roll technique, you resect the mass, the nodes, whatever the goal is. That may or may not require adjunctive procedures. And sort of a hard and fast rule that I teach fellows is sort of to do the easy parts first, the hard parts get easier. Every step of an operation should make subsequent steps easier and safer. And again, fundamental to that is really knowing your anatomy. So there is a very generous incidence of anomalies in the retroperitoneum, vascular anomalies, urologic anomalies, and you have to be aware of them, recognize them before you get started. I'll show you a few examples. Here's an example of a left-sided cava, an axial and coronal view, a duplicated cava, duplicated ureter, a pelvic kidney, a horseshoe kidney. This is a left retroaortic renal vein. Normally, when you're looking at scans, as you know, the left renal vein will course anterior to the aorta, and you don't see the base of the SMA well. If you see the base of the SMA as well as you do here, in this where I have the arrow, you should think of a retroaortic renal vein, and here it is coursing behind the aorta. And here it is in a coronal view, a mass here. And these left renal veins will have all the usual branches, the gonadal, the adrenal, perforating vessels, the descending lumbar. And again, you don't want to tie it off thinking it's a lumbar. You don't want to be marching up the aorta, looking for the renal vein, and then march into the SMA. So this, I see this about 3-4% of the cases. And again, you want to know this up front. In my opinion, and this is just my opinion, I think the left renal vein is the most important landmark in retroperitoneal surgery. It tells you the SMA is right above it. It really is just the most important landmark. The renal vessels, the renal arteries are behind it, and so forth. So finding that left renal vein is critical. This is an example of a circumaortic renal vein to the left with an anterior limb right below the SMA and a posterior limb behind the aorta. This is what it looks like in real life. And accessory renal arteries are extremely common. Almost a quarter of patients will have multiple arteries, and those are best viewed usually on coronal images. So again, we do the vast majority of these cases through a midline. Occasionally, for very bulky suprahilar masses, we'll use a chevron. Have not done a thoracoabdominal in more than 25 years. And so exposure is critical. We divide the falciform ligament after you make your midline incision, put in our self-retaining retractors, and place the transverse colon and greater omentum on the chest on warm packs. And here is what that looks like, the transverse colon, the omentum. And then you want to get to the retroperitoneum. And you want to incise the posterior parietal peritoneum, and you want to incise it in a very specific plane, medial to the inferior mesenteric vein and lateral to the right gonadal vein, which is going to course underneath the right colon. So you make the incision, and you come around the cecum and go up the right gutter, cochlearize the duodenum, and exteriorize the bowel. So here's your inferior mesenteric vein. Here's where you start your posterior parietal peritoneum incision. You take it around to the cecum and up along the gutter. And again, it's critical to stay lateral to the right gonadal vessels. The right gonadal vessels should drop down. If you're medial to it, it will stay up attached to the colon as you bring the colon up, and that will be a problem. So having accomplished that, you have the transverse colon, the right colon, the small bowel up on the patient's chest, either in a bowel bag or with very wet laparotomy pads. And again, it's hanging really on the SMA. And you have the pancreas mobilized, the duodenum cochlearized, and this is all sitting on the chest. And just a couple of comments. Some of these procedures can take quite a bit of time. And with time, you have a lot of third spacing. And this bowel and mesentery sometimes can get very heavy. So you want to be checking the bowel periodically, because sometimes the weight of the bowel and mesentery can pull on the SMA, and you don't want to see that avulsed or partially avulsed. So it's just something to keep in mind for long procedures. You want no tension on that SMA. So then next, you want to find the left renal vein. Again, the bowel is all up here on the chest. You want to find the left renal vein, and you can see there are a lot of lymphatics underneath the undersurface of the pancreas and duodenum. You want to clip those or tie them. Here's your IMV, and behind all this tissue and lymphatics is going to be your left renal vein. There it is. And you want to just clip all this tissue, connect the vein to the cava. And here you see all these clips on the undersurface of the duodenum and pancreas. Here you are dividing that tissue. And again, there is an avascular plane. Once you've done that and skeletonized the vein, there's a plane, an avascular plane between the IMV, which is a peritoneal structure, and the left gonadal, which is a retroperneal structure. And by incising along here, you develop a thick band of tissue, which is very rich in lymphatics. And you divide that band, and what it does is it releases the tail of the pancreas, exposes the distal left renal vein and the para-aortic space. Sometimes, if there's bulky disease in the para-aortic space, you can sacrifice the inferior mesenteric vein. And that's what this looks like. Here we are dissecting in that avascular plane between the gonadal and the IMV, and you develop this thick band. You divide it between ties, and again, it releases the tail of the pancreas, exposes the distal left renal vein, and exposes the para-aortic space. And again, this is very rich in lymphatics, and it's one of the areas where if you don't control those lymphatics well, you end up with these bottles. We're all familiar with it, paracentesis with chylous ascites. And areas that are very rich in lymphatics, that area between the IMV and the gonadal, the lymphatics surrounding the SMA, and behind the right renal artery, left renal vein, right renal artery, the cisterna, which, as you know, will drain into the thoracic duct. There are also a lot of lymphatics behind the renal vessels, but these are the major sites for lymphatic leaks. And risk factors for ascites and chylous ascites include, suprahilar dissections, caval resections, hepatic resections. So the bowel has been mobilized, you've developed that plane, you've released the tail of the pancreas, and you're ready to put in your retractors. And notice you want to put in your retractors on either side of the SMA. You don't want a retractor sitting on the SMA, and you don't want tension on these retractors. This is what it looks like intraoperatively. This retractor, the pancreas is behind that one, the duodenum and head of the pancreas behind this one. Here's your left renal vein, and right there between the retractors is your SMA, which, as I told you, is a key. This key anatomic relationship is just fundamental to not getting lost and having, potentially catastrophic injuries. So that's how we set that up. And if there's too much tension on this retractor, this is what you can end up with, a pancreatic injury, very high on the list of things you don't want to deal with. And the way to avoid it is, again, knowing that anatomy, releasing the pancreas, not putting traction on the retractors, which you have placed very deliberately. And once you've done all that, you're ready to resect the mass, do the lymphadenectomy. And what you are essentially doing is skeletonizing the great vessels, subtracting the masses and nodes from the great vessels. You divide the lumbar arteries and veins, and what you're going to be left with is a skeletonized aorta and vena cava. And this is what that is going to look like. Here's your cava skeletonized, your aorta skeletonized. This is a bilateral, and here it is diagrammatically. Simon Kim, a former fellow, a very talented artist, did a series of illustrations for a chapter. And the bilateral template from the renal vessels down to the bifurcation of the common iliac arteries from ureter to ureter, and posteriorly the anterior spinous ligament and psoas fascia. That's your bilateral RPLND. Now, the problem with an operation like this operation is that it resulted in almost 100% retrograde ejaculation, which in testis cancer patients is a very significant issue. Most of these patients are young, in their 20s and 30s. And so investigators look to address this problem of retrograde ejaculation. And the first attempt to address that was to modify this bilateral template and introduce modified templates. And given that the metastatic pathways to the retroperitoneum tend to follow the course of the gonadal vein, here are just a few examples of right modified templates. And you can see the perimeter, the surgical perimeter varies. And there were at least a dozen different templates. So here are a few right-sided templates. Here are a few left-sided templates. And the concept of the modified templates was to avoid contralateral dissection, spare the nerves responsible for antegrade ejaculation, and avoid surgery in areas thought to be at low risk for disease. So how was the risk for disease determined? And it was based on mapping studies. There were 3 excellent mapping studies. This was the best out of Indiana, Donahue. And you can see for right-sided tumors, each dot representing a metastatic node. So again, a fairly predictable in low-stage disease pattern of metastasis. And for left side, you can see the para-aortic and the pre-aortic are more common areas for disease. So that was one mapping study. This is a second mapping study, essentially reproducing the original mapping study with each dot representing a metastatic lymph node. The problem with mapping studies on which modified templates were based is that they always underestimate retroperitoneal disease. Always underestimate disease. Why? Because without adequate follow-up, you can't tell how many additional dots would appear in a year, 2 years, 5 years. So that's problem one. Problem two is in this disease, there's very effective cisplatin-based chemotherapy, and many of these patients received postoperative chemotherapy. You don't know how many dots would have appeared without chemotherapy. So the fundamental basis for modified templates is severely flawed. And how much disease would be left behind? How much extra template disease would be left behind with the various templates? And we did a few studies looking at various templates. And let me just show that we were part of the template crowd for a while. And you can see this is our template and the areas that are included in the dissection. And we looked at 5 templates, having done bilateral templates as of 99, 98. And Scott Egner, who was a fellow at the time and is now at University of Chicago, looked at extra template in disease in low stage germ cell tumor. And you can see that there is a significant amount of extra template disease that would have been left unresected had we not done a bilateral template. And again, the percent will vary depending on the perimeter of the template. That's true for right-sided and left-sided primaries. Brett Carver did the same study with your own Bobby Shagan, who is now at McMaster. And in advanced disease, the same thing. A lot of extra template disease, and again, depending on the perimeter of the surgery, that will fluctuate. But the bottom line is modified templates leave a lot of unresected disease. This is Indiana data in their Reoperative series, again showing substantial extra template disease, both for right and left-sided primaries. And this is European data. And over, it's the same message. Modified templates, from an oncologic point of view, are suboptimal. And here are the percent of patients who have only contralateral disease with negative ipsilateral nodes. So modified templates leave a substantial portion of the retroperitoneum vulnerable. And that results in relapses, late relapses, reoperative surgery, all bad things, all resulting in inferior outcomes. So in my view, and template surgery still around today, but in my view, it is a suboptimal approach. It's a suboptimal operation, and should be delegated to the history books. So first, addressing reoperative surgery, 3 out of 4 cases for reoperative RPLND involve the para-aortic or the left hilar area. That's true for patients that initially present with low-stage disease. It's true in the post-chemotherapy for advanced. 3 out of 4 are going to be in the left para-aortic, left hilar area. And why is that the most common area for reoperative surgery? First, right-sided templates never go there. So that area is left totally unoperated. You can have right to left crossover, as I've shown you in all those studies quantifying extra template disease. So that's reason one. And reason two is the para-aortic area is technically more demanding in terms of skeletonizing the renal vessels, releasing the pancreas, and really cleaning that area out well. So modified templates and a more technically demanding area to operate in. That's why this is the most common area for reoperative surgery. And reoperative surgery results in lower survival in a disease where your overall survival should be over 96, 97%. In advanced disease, you can see a substantial drop in survival. Reoperative surgery is an independent adverse variable for survival, independent of marker status, number of chemotherapy regimens, pathology, and so forth. Just the mere fact that you have to do the surgery again is an adverse variable for these patients. And it's true in low stage disease as well. And effective chemotherapy will not compensate for suboptimal surgery. So node counts. Node counts, you can see on the x-axis, total number of nodes, and on this axis, number of positive nodes. So the more nodes you resect, the greater the chance of finding a positive node. And the probability of finding positive nodes essentially doubles. It dichotomizes at around 40 nodes. So the bottom line is the more you look, the more you're going to find. And ipsilateral disease predicts for contralateral disease. That's true for right side and for left-sided primaries. There's more right to left crossover than left to right crossover. But ipsilateral disease predicts for contralateral disease. Again, just making the case over and over again against modified template. This is Toronto data with Rob as senior author here, showing that increased node count is associated with decreased risk of relapse. So this is not one of those cases where less is more. You see that phrase used over and over. Less is less and less is worse. So in 98, end of 98, we abandoned, again, we were part of the modified crowd, and we abandoned modified templates. And what we saw is in low stage disease, the relapse rate dropped substantially. Again, better patient selection, but a better surgery. This was an independent variable. The bilateral template, in addition to more stringent patient selection. In advanced disease, same thing. Better patients, better patient selection, smaller masses, but a complete bilateral dissection was the most significant factor. And you can see with time, relapse rates dropping and better patients, but better surgery. So how to better address the issue of retrograde ejaculation without compromising the oncologic component of the operation? And the answer is nerve-sparing bilateral retroperneal lymphadenectomy. And nerve-sparing implies dissecting, finding the sympathetic chains, the postganglionic sympathetic fibers, the hypogastric plexus. You dissect them, you isolate them, and you protect them throughout the procedure. And that obviates the need to reduce a template to preserve antegrade ejaculation. It reduces the risk of understaging and undertreating the retroperitoneum. Now, these nerves are delicate, it takes time, but when you do this, you don't have to compromise your surgical perimeters and the oncologic component. And the very first series of nerve sparing was again from Toronto. Mike Jewett described this, 20 patients with a preservation of ejaculation, I believe, in 18. And more recently, Nick Power, when he returned to London, he was a fellow here and returned to London and did very, very elegant anatomic cadaveric dissections to further define the neurovascular anatomy of lumbar vessels and sympathetic chain. And this is one of the studies. There are several, and they really are beautiful studies. And he showed that lumbar arteries are usually paired. Lumbar veins are not paired. Lumbar veins, particularly the middle lumbar, often will bifurcate and trifurcate. So again, and he pointed out the issues with the descending lumbar vein, which can be a source of bleeding and problems and when you do these surgeries. So again, understanding in depth the neurovascular anatomy, particularly as it pertains to the lumbar vessels, is critical to be able to achieve good results with nerve sparing. And you can see here's your cava. There are usually 3 or 4 lumbars between the renal vein and the bifurcation. The top one tends to angle upwards. The middle one often bifurcates or trifurcates, and there often is a posterior branch that will go underneath the cava laterally. And you need to know about all these branches because if you miss one, obviously you can have substantial bleeding. And then there's a few perforating vessels up and down the cava. Perforating vessels are small, but the issue is you don't want to rip them. It's better to cut them than rip them because the tear can go right down the iliac. And then a small problem becomes a big problem. Here's your aorta. You have the right and left sympathetic chains, the postganglionic sympathetic fibers, and they coalesce around at the level of the IMA. And this is what it looks like. You have the right sympathetic chain, which you need to preserve behind the cava, the left one lateral to the aorta, and the hypogastric plexus at the level of the IMA, and the postganglionic fibers coming underneath the aorta, the cava, on top, anterior to the aorta. The ones on the left travel along the side of the aorta. So what are the implications in terms of an RPLND and nerve sparing? Well, lateral to the cava, there are no sympathetic nerves, so you can dissect liberally here. You want to just stay lateral to the sympathetic chain here. You want to tie off your lumbar vessels, and you want to find your postganglionic sympathetic fibers. Here you can find them as they take off from the sympathetic chain. Here we have divided the lumbar vessels, and importantly, you can see that the lumbar vessels insert medial to the sympathetic chain. So as you know, if sometimes these vessels get away from you, you want to know where to look for them, and they're just inside the sympathetic chain. You retract the sympathetic chain laterally and find the vessels rather than throw big sutures there and injure the sympathetic chain, and then your nerve sparing obviously is compromised. So this is what it looks like. This is a key relationship where the lumbar vessels insert medial to the sympathetic trunk. And this is what it looks like in real life. Here's the cava lifted up. Here's your sympathetic chain, ganglion, and you can see the vessels clipped and tied just inside the sympathetic trunk and the nerves taking off underneath the cava. You can also find the nerves in the interarticular space, as they come underneath. Here we have rolled the cava laterally, and you can find the nerves here as they go anterior to the aorta and trace them down to the hypogastric plexus. So dissection in the intercaval space, again, we have found the postganglionic sympathetic fibers either in the intercaval space or in the paracaval space underneath the aorta and trace them out. You want to always split and roll over the cava first, because if you split tissue along the aorta first, you will end up damaging and cutting all these nerves. So you want to find the nerves first in the paracaval or intercaval space first, and then once you've isolated them, looped them, retracted them out of the way, then you can split over the aorta. Now, nerve sparing is never done at the expense of the oncologic component of the operation. If it's not feasible, it's not feasible. Your first priority, obviously, is to do a good cancer operation. So, and what about the para-aortic dissection? So here we are. Here's the left gonadal. This is a descending lumbar, and you can see it's very close here to the sympathetic chain on the left. Here are the postganglionic sympathetic fibers on the left. And again, this vein here can be the source of a lot of aggravation, so you need to know that it exists, control it, and save you a lot of grief. And again, this is the area, as we've discussed before, that has the highest potential for infield recurrences. And again, this is what it looks like, different view. The aorta has been lifted. Here's your sympathetic chain, the postganglionic sympathetic fibers. The lumbar is here. And again, you want to be aware of it. It can also bifurcate, and you want to make sure you get all the branches, because if you get into bleeding there, it can be a bit of a problem, and you end up with renovascular injuries and injuring the sympathetic chain and so forth. And this is what it looks like in real life here. Here is the sympathetic chain on the left side. The aorta is lifted up. Here are the lumbar arteries. And you can see the lumbar artery inserting just inside the sympathetic trunk. So again, if it gets away from you, you know where to look for it. Here's your renal artery, your left renal vein, the intercaval space, and we've isolated the nerves on the right side. You can see here's the hypogastric plexus and the right postganglionic sympathetic fibers up here. And if you do nerve sparing, you're able to preserve ejaculation in low stage disease over 95% of the time. And in the post-chemo setting and more advanced disease, even with bulky disease, you're able to preserve ejaculation almost half of the time. And this doesn't compromise your the oncologic component of the surgery. This doesn't leave extra template disease behind. This, in my view, should be the standard. It is not in many places. You have fierce debates about modified and bilateral. I believe the data is just too compelling. I do a lot of reoperative surgery from, including a couple of my own from back when I was a modified, part of the modified crowd. And there's just no good reason to do modified templates. This is a case of a young boy, 13 years old, that ended up after having initial surgery elsewhere and ended up at Memorial. And whenever you do reoperative surgery, I always teach the fellows to go back, read the initial notes to see what they've done, what they've not done, and gives you a sense of where they've been and so forth. But in the note, here we say, here is, we knew from the beginning we would not remove all the gross tumor. And in germ cell and testis cancer, you don't get credit for doubles and triples. You either have to get it all and achieve a complete resection. So you either get everything or you get nothing. There's no credit for debulking. That's an incomplete resection, and you have, in fact, created an additional adverse variable for this patient. Achieving a complete resection sometimes requires adjunctive procedures, the most common one being nephrectomies. 3 out of 4 tend to be on the left side. Here are 2 examples of cases that required nephrectomies. This one required a lot more than that: nephrectomy, splenectomy, distal pancreas, left colon. This one required left colon, left kidney. So whatever it takes to achieve a complete resection. People have replaced great vessels, grafted vessels, and so forth. But nephrectomies are by far the most common adjunctive. Here's an example of a right kidney, again, unusual because most tend to be on the left. And again, knowledge of anatomy is what gives you a fair shot, and more importantly, the patient a fair shot at a good outcome. Because often the structures are not going to be where they're supposed to be. And when you see them displaced, that's actually, in my view, I prefer to see that because there tends to be less invasion of structures when they're displaced. That's just an anecdotal observation. Our nephrectomy rate is 6%. We work very hard to save kidneys. And even in this case here, bulky disease. And again, the relationship's critical. Here's your left renal vein, your SMA. It's very easy to get lost with these very bulky masses. Here are your renal arteries. And again, we were fortunate. We were able to save both kidneys. Here he is 6 years out. And again, technique matters. Certainly don't want to underestimate that. But I think without question, in my view, just an in-depth knowledge of the anatomy is absolutely critical. Cases like that will require suprahilar dissections, maneuvers to achieve preservation of kidneys. You defat the kidney, sometimes find the vessels in the hilum, and then trace them out to the great vessels. Suprahilar dissections, often associated with increased morbidity, renovascular injuries, pancreatic injuries, and ascites. So, tried to make the case that in-depth knowledge of the relevant anatomy is essential to any surgery, and that's certainly applicable to retroperneal surgery and retroperneal lymph node dissections. It optimizes preoperative planning. It maximizes your exposure. It reduces adverse events and optimizes your clinical outcomes. I think the retroperitoneum illustrates this as well as any other area and any other operation. Once the decision is made to perform node dissection, you want to maximize both the staging and the therapeutic potential, and bilateral templates accomplish this. Modified templates unnecessarily increase the probability of unresected metastasis. Nerve-sparing techniques obviate the need for reduced templates, a better understanding of the neurovascular anatomy of the retroperitoneum and the anatomy of the lumbar vessels and the neurovascular anatomy that's involved with antegrade ejaculation has dramatically changed the face of this operation. And for these operations, it's my view that they're best served in high volume centers. I think germ cell tumor epitomizes the multidisciplinary approach to any disease as well as any. And I'm very fortunate to work with just superb people across all the disciplines. I've been very, very fortunate throughout my career to have had great mentors and great teachers. Could never have dreamt of tackling some of these things without their patience and their support. And again, some familiar faces here. As Neil mentioned, there's a very long history between Memorial and Toronto. Not all of these are Toronto, but most of them are. Rob, Girish, Bobby, and Neil doesn't do group photos, but here he is. We're old friends. And again, this has been a huge privilege. I want to thank you very, very much for this kind invitation. Really an honor. Thank you very much. And I'm happy. I hope there's left time for a few questions or comments if there are any.
Great. Thank you so much, Joel. Excellent lecture. It really does, I think, show the I don't know, the sort of the boundaries of surgical prowess in many ways. How we can take apart an abdomen like that and put it all back together. It's a lot. I know it's been a career of work and quite amazing. Maybe I could kick off the first questions if there's not. I know there's a move. Maybe Rob can comment to approach this robotically now. And I'm curious your thoughts about that. Certainly Twitter is alight with these sorts of photos. Yeah,
that's a loaded question and highly emotional, and that's the source of a lot of debate. It's been debated in many forums. We do not do it minimally invasive. It is done successfully. We in Indiana, they also are not doing robotic RPLNDs. There are some specific issues with robotic RPLNDs, unusual patterns of recurrence, some issues with carcinomatosis, and having seen some of them, don't think really it's as thorough. They rely heavily on adjuvant chemotherapy postoperatively. But I think the horse is out of the barn on that one. I think it's been adopted in multiple centers. We have not. But again, that's a very long discussion. I will also say that I do about 8 or 10 reoperative surgeries a year, and reoperative surgeries after MIS are extraordinarily difficult for reasons that I really don't understand. The desmoplastic reaction is brutal. It's even worse in my experience than that you encounter in post-chemoseminoma, which is sort of the epitome of desmoplastic reaction in our disease. And again, you see studying and implants and just patterns of relapse that you don't see with open surgery.
Rob Hamilton, I see your hand up, and then we also have one after that from Tom Lindsay in the chat.
Yeah, thanks. And thanks, Dr. Scheinfeld. That was outstanding. And not to get into the robotic discussion, but I think we agree on many, many more of the principles. We do robotic surgery here, but I think we so much approach the way that you have outlined in your talk. We basically adhere to all the principles, but I think you're right. Most of the world, unfortunately, does not. And you get these Twitter fandoms of these gorgeous modified templates where they leave half the retroperneum undissected, and I think it's a shame. But my question was more about quality, and you actually only mentioned it right in the final line of your summary. But all these principles that you talked about come with experience, and so I'm curious your thoughts on who should be doing these surgeries, regionalization of care, not just for testis cancer, but for the approach of the entire retroperitoneum for these complex dissections.
Sure. Look, there are many studies that show a clear correlation between volume and outcomes. And I think anybody who does one, two, or three of anything, really shouldn't do it and send it to the people who are doing high volume or for whatever it is. There are a lot of things I have no business doing, and I don't. I send it to whoever happens to have an interest. They have an interest. They have an interest in doing it better. They've studied it better. They understand the subtleties. So I think regionalization of certainly complex procedures is just common sense, quite frankly. And I didn't really have time to show the demographics of RPLNDs, at least in the United States, but the Board of Urology has studied that and looked at the exposure of RPLND surgery for residents. And Will Lawrence published that when he was a resident at Vanderbilt, and more recently, Josh Meeks. And 10% of residents in the United States never even have seen an RPLND. If you did two in your residency, you were in the 50th percentile. So the bottom line is the vast majority of board certified urologists have had minimal exposure. And there's so much at stake here because if you've done them right, the outcomes should be good. These are young patients, and you have to make the right decisions and execute these decisions optimally. These are 20-year-old patients. They've got 50, 60 years to go. You've got to be right for a long time. So I think these cases, along with others, should be performed in places that are comfortable and have experience.
Thanks. We have maybe a quick answer, and then Dr. Klotz will have the final question. Tom Lindsay asked, who's a vascular surgeon, how often have you had to do vascular reconstructions such as aortic resection in these cases?
Aortic replacements with grafts have been reported. We have been fortunate. I've not had to replace an aorta. I've come close, but managed to avoid that. But other centers have reported resecting aorta and replacing it with either a tube graft or a Y graft. The Cava, different story. We have replaced a few Cavas. But usually when the Cava is so compromised or occluded, there's a lot of collateralization. And sometimes if you just take it, there's enough collateralization and people seem to do okay without replaced Cava.
Jim, do we have time for Dr. Klotz? He had his hand up.
Yes, of course.
Thanks.
Thanks.
Make it easy, Laurie, please.
No, I just first just a comment that I think your terrific talk and your career are just a testament to the benefits and value of focusing a surgical career in a specific area. And you've as many, but maybe not all of the participants know how you have single-handedly advanced this whole area to a significant degree by focusing on RPL for testicular cancer for now decades. And my question was about how to deal with this issue that you've addressed of the suboptimal RPL. And you mentioned that 40 lymph nodes was kind of a dichotomizing number in terms of quality assurance. So would there be a role, for example, for adopting a policy of adjuvant chemotherapy after an RPL, a pre-chemo RPL, where less than 40 nodes were resected?
Well, thank you very much for the kind words. Really very much appreciate it. Node counts is a complex issue because I think the pathologies are equal co-participants, and If you have very dedicated and interested pathologists, I mean, they'll come up with bigger node counts. If you submit the specimens in multiple packets, the yield tends to be higher. I mean, it's a complex issue in terms of achieving node counts. Whether it's a surrogate for quality, it should be. I know that in other diseases, they require a minimum number of nodes. I don't know that if you don't achieve 40, whether just across the board chemotherapy is advised. I think more than the number of nodes is well, number of nodes. I mean, I don't want to make the case against it because I think it's important. And your data shows it better than ours because your data shows more relapses with lesser counts. But I think certainly modified template puts the patient at risk. Sometimes you will see pathology reports with 8 nodes, 10 nodes, 6 nodes. I mean, you really have to question things like that. I think when we do a node dissection, unless they have very bulky, like those very large cases I showed you at the end, we only do one postoperative CAT scan as a baseline, and then we don't image the retroperitoneum unless there are clinical indications, patients running fevers, or there are reasons to scan them. Otherwise, we do one scan and that's it. But if somebody's had what you think is a suboptimal retroperitoneum or a modified template, half that retroperitoneum is at risk. It's vulnerable. You have to follow it. So I think you've really not accomplished what you should have set out to do.
Thanks.
Okay, well, look, just because the time has passed, I would like to draw the Harland-Smith lecture to a close and to thank Joel sincerely for an outstanding lecture today on behalf of the Department of Surgery. Joel, we do have some gifts coming your way from the Department of Surgery. We'll send those to you directly as small mementos of our appreciation for your lectureship today. I think we can all appreciate that anatomy is alive and well, not only in the division of urology. This was a great example today, but throughout all of surgery. And special thanks to Cindy Mooreshead and the Division of Anatomy for allowing us to have the Harland-Smith lecture today. So on behalf of the Department of Surgery, Joel, once again, thank you. Thanks to all for joining today. Happy April Fools to all. Okay.
Yeah, thanks.
All the best.
Again, many thanks to all, to Neil, to Cindy, and to you and everybody. It was really a pleasure. Thank you very much.
Thank you, Joel. Thanks, folks. See you.
Thanks.